Many of you are going into an operatory, seeing a patient with a problem, and trying to verbally describe it to them. Well, they can't understand it. If they're like me, I'm a visual learner. If you try to just explain something complex to me, I'm not going to get it. I need to see it. I published these books to help me with dental education, and they are invaluable. I could not discuss treatment with a patient without them. The key here is there's no place for the word sell in dentistry. You're not selling a patient something, you're explaining. You're making them aware of what pathology is and what treatment options are and what their condition is. So this is what decay looks like in the initial phase. Little dot in the enamel, then once it gets into the dentin, it's a small area in the dentin. That's how you like to catch decay. This picture has been so worthwhile to me because this little area right here of decay you don't even see. This one looks moderate, but once I remove the enamel from that area, you can see this small area is that large, and this area was actually decayed into the nerve of the tooth. That tooth received a root canal. So when a patient looks at this, they realize there's not some big black hole on top of the tooth. Decay is very subtle in the enamel. This was a Baylor student with, then this is how he presented with these black dots in the enamel. Well, once I remove the enamel into the dentin, you can see how explosive this decay was, and this student received 10 root canals and 10 crowns. So what we're trying to get away from is you seeing a patient in an operatory and trying to explain with words what their condition is. That's never going to work because they can't visualize it. But when they see this and then they see photographs of their teeth and the same situation is present, they understand what it is. So that's decay. This is leakage around old mercury amalgam fillings. And what I say is mercury amalgam fillings don't bond to teeth. They're held in by mechanical retention, meaning the bottom part of the filling is wider than the top part. A mercury amalgam filling can wallow around in the cavity preparation for years and still be present in the tooth because the bottom part is wider than the top part. But as you can see by these old fillings, once I removed them, even this small one, this was the decay that had occurred around and under that old mercury amalgam filling. This one was actually decayed into the nerve of the tooth. This one we got to in time and were able to remove the decay before it was into the nerve of the tooth, and because it was a smaller filling we could restore that one with a bonded composite filling. This tooth though that was decayed into the nerve of the tooth, I had to perform a root canal and a crown, and these are just other pictures of leaky fillings. So you show the patient that, and then you show them pictures of their own teeth. You're not trying to sell somebody something. Our job as practitioners is to give the patient enough information that they can make an informed decision about what, if any, dental treatment they'd like to have performed. So these are cracked teeth. So when a person bites on a tooth and they say, "Oh, that tooth hurts," and you see a big crack, I'll show them these pictures and you can see the crack on the end of this filling. And once I remove the filling, you can see the crack running front to back, mesial to distal. And here is the same tooth. They can see the crack running into the nerve of the tooth. And I say that's when you have to have a root canal and a crown. Because when you bite down, those pieces separate and it causes pain. And if you can get to it in time, you can save the tooth with a root canal and a crown. If you don't get to it in time, like this gentleman, I talked with him about the cracks in his teeth about a month previously, and he returned to the office a month later and had split that tooth right down the middle. You know, it doesn't mean that they have to do something to every crack in a tooth, but when it's a significant crack and they keep chewing on that tooth, most of the time those teeth are going to continue to crack deeper into the tooth. This is decay under old crowns. This is before composite cements, and back in the old zinc phosphate days, whenever you'd have leakage under an old crown, it would decay underneath there, and these are pictures of what was under a leaky old crown. Now, I could try to describe this to a patient for hours, or I could show them one picture and they're going to understand it. This is a decay under that crown, and that was what was left of that tooth once I removed the decay. This is abfraction, and of course this occurs when someone clenches their teeth, not so much grinding but clenching, because that's the flex point. And what I tell patients is the root of the tooth is secured by bone, but when they clench their teeth, they flex it just like you're flexing a bobby pin or a paper clip. And over time, as you flex, they flex the enamel off the facial surface of the tooth. And this is after I've restored it. But I tell them, if you don't have a night guard, if you continue to flex those teeth at night when you're sleeping, you'll flex that composite bonded restoration off the teeth. So we show them what a night guard looks like. And we explain how this keeps them from clenching tooth to tooth. They grind on the night guard. You can't make someone stop grinding their teeth or clenching their teeth at night. But what you can do is protect the teeth, so whenever they do clench, they're clenching into this night guard. And the night guard is a hard acrylic night guard. It's not a soft football mouth guard type, because if it's a soft type, they can get traction on that and they can give themselves myofascial pain or a TMJ problem. The next section is interproximal decay, and this shows how there's always decay on both adjacent teeth when there's interproximal decay, because the food sticks in between the teeth, the bacteria secretes the acid, and you get decay both ways. These are chipped incisal edges of upper and lower anterior teeth, and this shows how that occurs. When the patient rubs their teeth together, they get that little thin edge, and then that breaks off. And so what we do to protect it is place some composite bonding on that edge and give them a night guard, because if they don't have the night guard, guess what? They're going to do this again. Lower anterior teeth bonded there. These are large fillings, and this is a very important section, because what it shows is a large filling down the center of a tooth is like Abe Lincoln splitting those logs with a wedge in the logs. There's nothing holding this side of the tooth to that side of the tooth. And so when you have a large filling, we like to place a crown over the tooth to hold the sides of the tooth together so they don't fracture the tooth. See the cracks in these teeth? That person is going to split that tooth. See how this filling is breaking down, because there's nothing holding, the tooth is breaking down, there's nothing holding this side of the tooth to that side, so when they bite right there or bite on this cusp or this cusp, it's not held together. So in these cases, ideally you place a crown or a cap on top of the tooth to bind the sides of the tooth together so they don't fracture it, or worst case, split it right down the center and then have to have an implant or a bridge. So these are crowns placed on these teeth with the cracks. Now this is an important picture right here, because it shows that this mercury amalgam filling is leaky, but it's smaller, and there's no crack on the tooth, and there's good tooth structure all the way around it, so that tooth doesn't require a crown, especially if the patient receives a night guard. We've just replaced that filling with a bonded tooth-colored composite. Then this is an important picture showing how when people rub their teeth together at night, they sharpen the lingual or the back side of the lower anterior teeth, and the front side or the facial of the maxillary anterior teeth and create those little thin edges. And then they bite down. They'll be biting on a piece of bread, and they say, it broke when I was biting on a piece of bread. Well, it's because you didn't have any tooth structure there. You'd worn it away. And so in these cases, those patients must have a night guard, and you restore that with sometimes you can restore it with bonded composite, and sometimes it requires veneers. So that's the dental diagnosis book. This is the aesthetic restorative dentistry book showing patients what can be done aesthetically to restore teeth. So the first section is on porcelain veneers. Just shows a variety of different presenting situations and how we restored them with porcelain veneers. So patients can see what the restoration looks like. I always say, I feel like a home remodeler, and if a person was remodeling my house, they could talk all they wanted. What I want to see as the client of a home remodeler are houses they've restored. I want to see what they think a good restoration looks like. So we've got all these different cases. Bad veneers, restored those with veneers, and replacing veneers there with these. Just a person with discolored teeth, a reverse curve, big composites, veneering those teeth. Second section is periodontal crown lengthening. She had short teeth, and so I've lengthened the teeth with periodontal crown lengthening, and you can look at a video in dentistry master classes on how to periodontal crown length. Remember, periodontal crown lengthening is not gingivectomy, it's ostectomy and gingivectomy if you want it to last. And so I've veneered the teeth after crown lengthening. This section's on crowns. These are some old porcelain to metal crowns, and we've redone them either Emax or Max or all porcelain, or Emax or porcelain to zirconium. Just some old porcelain to metal crowns, and we've redone them and corrected the incisal plane. This section's on crowns with veneers. Just had some old patched up stuff with porcelain to metal crowns, so we've restored them with current crowns. Corrected the incisal plane. When patients see photographs, it's magic. I've always said I think I could do a consultation and not say a word if I had these books and photographs of the patient's teeth, and all I would do is just point to the pictures. This patient was a pastor from a town about 3 hours from here, and he came to see me to have his teeth corrected. And after I'd done the interview and he walked back to the back for the examination, his wife said his teeth look like a weasel. And they really do. The proportions aren't correct. So you can show them what they look like when the proportions are corrected. This person was hit in the mouth with the boom of a boat, and this is how we could correct that. Fix bridges. This is a good Texas case. This gentleman's from a town about 3 or 4 hours from here, and he got between a cow and her calf, and the cow's horn got in his mouth somehow and knocked that tooth out. So I had to graft it and then place this fixed bridge. Really nice fella. Implants. This gentleman was in a car accident and lost his lower anterior teeth, and so we placed 2 implants here and a lower 4-unit fixed bridge to those implants. These are severe wear cases, increasing vertical dimension. See how they've worn the teeth away? This shows why you don't want to drink Coca-Cola. It's like, I always say, it's like battery acid with sugar in it. Severe wear. I've increased his vertical dimension. This gentleman's wife had passed away, and he said, I'd like to date again, but I can't go out with anybody looking like that. And so after we finished this, about 6 months later, he comes driving through Waco with this beautiful woman in his convertible driving to Las Vegas. So I guess the restoration was a success. This gentleman owned mines all over the world, and he said, I'm not going to have orthodontics. So he said, do whatever you can. And we'd restored his wife. And so this is what you can do. This is on bleaching. This gives a patient an idea of what the result they could get with both at home and in-office bleaching. This is internal bleaching. So the key is you show the patient the books before they look at photographs of their teeth. Why? You want them to see what restorative options are and what pathology looks like. Then at the consultation appointment, we have photographs of the patient's teeth. Now, Sharon, you were saying very back teeth on the lower right and lower left are painful when you bite together.
Yes.
Well, you can see when you look at these teeth, they've got large fillings in the teeth, and you remember the pictures we looked at in the book of leakage around mercury fillings. Well, a bacteria is 8 microns in diameter. This opening right here is probably several thousand microns. So that opening between the filling and the tooth is like the Grand Canyon to a bacteria. So they pour in there and decay underneath, and you can see the cracks right here. You can come up to this tooth and see that large filling and see you see the crack right there. And that's not a craze mark. That's actually a black crack. So it's going to extend under that filling. And when we look at the back of that tooth, you can see the cracks going down the back of that tooth.
I do see it.
Now, when we look at the other tooth, on the other side, see the big crack right there?
Yes.
Now remember, you're not a bad person if you don't do anything.
Wow.
You're not a bad
What
person
will
if you don't do
happen
anything.
if I don't do anything?
Well, you saw those other pictures.
Yes.
And it's like a crack on a windshield. Once they get that large, it just, typically if you keep chewing on that tooth, it keeps moving down the tooth until finally it gets into the nerve of the tooth, and that's when you have to have a root canal along with a crown, or if it goes too far, it can split the tooth, and then people have to have an implant.
How long would it take for that to happen?
Nobody knows. It could be the next bite you take, or it could be years, or it might never happen. You see
Is that bad for my health to have bacteria going into my tissue?
Some say yes. And you also can see right here, this is sticky. And you remember those pictures of decay. It's not a big black hole on the tooth. When I put my Explorer in that black area, it's sticky. And that's usually the only thing you see on the enamel. It's like termites in a wall. They don't make a giant hole in the wall. They pierce the wall and then get underneath it and eat the sheetrock and all that. That's what happens with decay. It makes an entry, and then once it gets into the dentin, the soft part, which is what it wants to get to because that's easy to dissolve, then it makes a big hole in the dentin. And a lot of times people appear with what they think is a broken tooth. Well, it's not a broken tooth, it's a cave-in. It's like a floor is eaten out and you step on it and it breaks through because of the decay underneath it. And we see a lot of people like this that have just been patched up all their life. So we've got big fillings on these teeth. You can see the crack right there. You can see the hole in the crown right there.
How did that get there?
Just grinding. You're a good-hearted woman, and you're solving all the problems of the world every night. So my suggestion would be a night guard. You know, most of our patients have night guards. Our daughters got a night guard when they'd quit growing when they were 16, and I told them, if you'll wear this the rest of your life, your teeth will be the same length they are right now when you're 80. All right, now the thing that brought you in here, a dentist had seen you had some chipped areas, and he'd ground those away. Now the thing about bonding, you can't bond predictably past the presenting length of the tooth. What that means is if you had a chip right here, I could place bonding up to that length. But if I extend bonding past the end of the tooth, there's a high likelihood it's going to fracture. So you've got beautiful teeth, but I would recommend porcelain veneers on these teeth if you're happy with the shade of the teeth. If you're not happy with the shade of the teeth, you know, then sometimes you extend veneers back to the bicuspid so you can create any shade you want.
I don't like the color back here.
Okay. What we can do is try to be conservative and bleach the teeth first and see where we get. See if the shade's light enough for you. If it's not, this person wanted light teeth. Well, you can't put 4 light teeth and then have yellow teeth. That looks
makes
bad.
sense.
So if you're going to change the shade, you extend the veneers back to the bicuspid teeth so someone looking at you from the side doesn't see yellow teeth.
That makes sense.
But let's bleach first, and then you might want to consider veneering these 4 teeth. Now also,
What about my lower teeth?
these teeth are chipped right here.
That doesn't look very consistent.
You can see you've worn and chipped those into the dentin of the tooth. I would consider bonding the incised ledges of those teeth like this. Does it help visualizing what it's going to look like?
Oh, I had no idea.
So the consideration in this case
That makes
was
sense.
veneers or bonding.
Okay.
And we elected to go a less expensive way with bonding and a night guard. You can see I've just bonded up to replace
Does
this
the
yellow
bonding
bond.
last like
No.
a veneer?
No, the bonding is not a necessarily a long-lasting thing if you don't really take care of it. I would suggest not biting hard things on the front teeth. As we discussed, a night guard's imperative.
What about these right here?
Good question. If you were a family member of mine,
I don't like the way those look when I see it right there. Gosh,
this is what I would do. If someone had those big cracks on the teeth, I'm preventive minded. You can see the crack going through here.
I see it.
See the big one here.
Yes.
This tooth doesn't have a crack on it. So I would replace that one with a tooth-colored composite, this one right here,
Okay.
like that. And the difference between these and these,
Okay.
the amalgams are held in by mechanical retention because the bottom part is wider than the top part. The composites actually bond into the teeth. Composites are good if they're small. If they're large, they're not good because the coefficient of thermal expansion, how much something expands and contracts when exposed to hot and cold, is much greater in a composite or a silver filling than a tooth. A composite or silver filling has a coefficient of thermal expansion of 75, whereas a tooth is about 11. So when you drink something hot and cold, that filling's going like that and the tooth's going like that. And it eventually pulls away and stains and leaks. The other thing, if it's large, there's nothing holding the sides of the teeth together like we saw in this case.
Oh my goodness.
And so you tend to fracture the
Wow.
teeth. But this would be
That
perfect.
looks like I may be about to do that in my tooth.
Yeah. So, as I've written on your consult, let's read this sheet together. Sharon, I look forward to assisting you with your dental restoration. During your examination appointment, you said bonding was placed on your upper anterior teeth yesterday, and you were not happy with the results. This was in another dental office.
Yes.
Nice guy, but you
Yes.
didn't like the final result. And he placed bonding, and then by the time when he recontoured it, he ground off this part of your
I didn't
tooth
like that part.
on these 4 teeth,
I
right?
didn't like that part.
You wish to have your maxillary anterior teeth cosmetically corrected. Additionally, you said
Maxillary, that's my upper.
yeah. Additionally, you said you have atypical trigeminal neuralgia, causing fairly constant discomfort and burning on the left side of your tongue. This discomfort has existed since 1995.
Yes.
We talked about
Yes.
the Gamma Knife
Yes.
people in Austin. We're referring you there to have them evaluate your trigeminal neuralgia. You wish to have the mercury amalgam fillings removed and replaced in your teeth, and would like possibly to have the lower anterior crowding corrected.
Yes.
Your teeth were professionally cleaned yesterday at that other dental office.
Okay.
Now what this was, I always give the patient a summary of why they came to see me, just so they know I've heard what they say. Examination results. There are several large mercury amalgam fillings in the teeth. Some of these teeth have significant cracks.
Yes. It was so clear when I saw those photographs.
Isn't photography
Amazing.
fantastic?
I had no idea.
Well, I am such a visual
I had
learner.
no
If
idea.
somebody just
That
tells
just
me
looks
something,
terrible.
it goes over the top of my
That's
head.
really worrisome right there.
Yeah. The maxillary anterior teeth contain medium to large composite fillings. Radiographically, there appears to be decay between your central incisor teeth and leakage around several of the old composite fillings. You can see this is decay, and then you've got some
That's decay.
pretty good sized fillings on these other teeth. Another reason we're considering veneers on those teeth. Gum recession is present on some of the molar teeth, exposing metal crown margins. And you said you didn't like the margins
No.
showing on those teeth.
I didn't realize how obvious it was until I saw that photograph. That just looks awful. It's the first thing I see now.
Well, you've got, you can see the dark fillings showing through these teeth. That's another issue with mercury amalgam fillings. I haven't placed a mercury filling in 35 years. Just, that's all we had at the time, but now we've got better things. But you can see the exposure right here. Yeah, there's some gum recession here. You've still got plenty of attached gingiva, so you're not needing gum grafting. The mandibular incisor teeth are worn. The two front teeth and the mandibular anterior teeth are crowded. So this is what we were looking at a while ago. We use a technique called clear correct orthodontic trays. It's fantastic for this type of crowding. So I'd place some bonding on these teeth, bleaching upper and lower teeth, and if it was me or you or my wife, and then veneer these 4 teeth and a night guard. There are 2 holes in the maxillary left second molar crown. Your oral cancer exam was negative, means you don't have any signs of oral cancer in your mouth. So this is the recommended treatment. Would be to bleach the upper and lower teeth, veneer the upper 4 incisor teeth. You'd have a wax up, bond the chipped incisal edges of the lower 2 central incisors, and place a night guard to protect the teeth and veneers from wear and chipping while you're sleeping. And then you'd be sedated, and here's your cost. Second part, or over time, because you said finances are an issue, would be crowns on the 2 upper bicuspids. Got the big crack here and the big filling here. Crowns here, and replace this crown. Might be something to consider on that molar that has the holes in it. And then composite fillings, just fillings are all that's needed on this tooth. You remember it's a small filling, and you don't have any cracks in that tooth.
I can see that now.
Yeah, and then you've got this decay on this tooth right here, so this would just be a tooth-colored filling. Then we've got the large cracks on the lower right and lower left second molars, and those teeth also have significant mercury amalgam fillings in the teeth. We'd place crowns on those to keep the teeth from continuing to crack into the nerve of the tooth or even split right down the middle. And then optional would be to replace the maxillary and mandibular right first molar and mandibular first molar crowns. That's the ones that have the gingival recession and the discoloration.
Yes, that looks bad. I'd like to replace those.
Okay. So that could be done in a part 2 or part 2 and 3 if you wanted to do that. Any questions for me about any of this?
Photography is a game changer. I had no idea they looked so bad because I'm used to looking at it just in my mouth, but when I see the photographs, I realize there's a lot going on over there.
I'm the same way. Like I said, I think of this as a home remodeler. And if I'm sitting in your seat and a home remodeler sitting right here, I want to see photographs
I understand.
of pathology, and then I want to see what that person has done to remodel the house and see if I think it's good
That
work.
makes sense.
This is how you use the dental diagnosis and the aesthetic restorative dentistry books when it's not a formal consultation, when you found some single tooth issue in the hygiene department or in one of your operatories. You've been having your teeth cleaned today with Ashley, and you said you're having pain to biting on this upper left first molar tooth. And I looked at it, and you've got a big crack in that tooth. Let me show you what that looks like. See the crack on the back of that tooth, off the back of that filling? Once I remove the filling, you can see that crack extends the length of the tooth. And if you follow to this picture, it's into the nerve of the tooth. So that goes into the nerve of the tooth. So when you bite down, moves those pieces, and it's painful. So the treatment for that is to take the nerve out and then put a cap on top of the tooth to hold those pieces together to keep it from splitting further like this.
I see.
Does that make sense, Sharon?
Yes, it does.
Is that something you'd like to have done?
I do.
Terrific. Let's make an appointment to fix your tooth.
Okay.